Good night, everyone. Thank you, Secretary Andre. Tonight, I have been given the pleasure of introducing a strong Black woman that has worked her way and made her mark in the health industry. She was given the name Roxanne, which means bright star in Kurdish. With piercing brown eyes, I believe her mother made no mistake. She started her educational journey of medicine at the University of the West Indies, Mona, where she completed her undergraduate Bachelor's of Medicine, Bachelor of Surgery with honors in 1992. She further went on to complete her Doctorate of Medicine in Pediatrics in 1998. Since that year of completion, she has worked in pediatric neurology at the University of the West Indies Hospital. In 2004, she decided to leave the country and pursued a clinical fellowship in the pediatric neurology at the University of Ottawa, Children's Hospital of Eastern Ontario, Canada. At the University of the West Indies, she wears many hats. She's a senior lecturer and head of Department of Child and Adolescent Health, a program director, a director of medicine in pediatrics, and a consultant and director of the Pediatric Neurology Clinic. Apart from the UA franchise, she practiced privately at the Kiddie Care Pediatrics in Kingston, Jamaica. Her main research interests are epilepsy in children, epidemiology, cognition and quality of life, and the neurological complications of arrival infections in Jamaican children. Most importantly, this God-fearing woman, along with her husband, Ron, are the parents of two amazing adult children. With all that mouthful, I hope we take our pens and papers out and get ready to be educated by the lovely Mrs. Roxanne Mebourne-Chambers on the fundamentals of maternal and child health.
Okay, good afternoon, Rotarians and members of the Rotaract Club of Mandeville. Thank you for this very kind invitation and this very kind introduction. Before I begin, I would just want to check that you're hearing me well.
Yeah.
Okay, yes. So I'm going to share my screen.
I mean, this normal local fever after the vaccine.
When the host allows me.
You can now share your screen, Dr. Chambers.
Okay, great, great. Thank you. Okay, so as asked to speak to maternal and child health, the fundamentals, and just as you did in your Rotaract minute, I really looked to the data that is published to just guide what I will share with you. So I have just a few objectives. Okay, so just want to start out by defining maternal and child health. Look at some published data that is relevant to us locally. Just touch on the impact of COVID-19, and then also probably to explore some opportunities for strengthening and help. So, maternal and child health really refers to the health of mothers, infants, children, and adolescents. And maternal health refers to the health of women during pregnancy, childbirth, and the postpartum period. Every day, this is from the WHO, every day in 2017, approximately 810 women died from preventable causes related to pregnancy and childbirth. However, between 2000 and 2017, the maternal mortality ratio, which is the number of maternal deaths per 100,000 live births, dropped by about 38% worldwide. The majority of maternal deaths occur in low and lower middle income countries. I don't know if we know that Jamaica is a middle income country. And young adolescents ages 10 to 14 face a higher risk of complications and death as a result of Sorry, I'm not just trying to remove this. Okay, right, as a result of pregnancy than other women. And so skilled care before, during, and after childbirth can save the lives of women and newborns. Okay, so the main causes of maternal mortality include hemorrhage, infection, high blood pressure, unsafe abortion, and obstructed labor. And as we said, younger adolescents face a higher risk of complications and death as a result of pregnancy. And so skilled care before, during, and after childbirth can save the lives of women and newborns. The standards for maternal care include that all pregnant women should have at least 4 antenatal care assessments by or under the supervision of a skilled attendant. And this is really to involve things like pregnancy surveillance, preventative measures, including immunization, screening for particular conditions and infections, recognizing early pregnancy-related complications, recognizing and treating underlying or concurrent illness or disease, and also to support the woman and her family in developing a birth and emergency preparedness plan. And then things like health education and promotion for the woman and her family. This includes things like also screening for symptoms of stress, domestic violence, and also helping the woman and her partner to plan around future pregnancies so that, you know, their expansion of the family can occur in a planned manner. So how are we doing? We see that this is Jamaica, data related to Jamaica. We see that this is from 2015, 87% of our women had 4 or more antenatal visits. And that is compared to the WHO in whole, on a whole, who had 86% of them having 4+ visits. So we're not doing so badly in terms of our women accessing antenatal care. And 96% of our women had their births attended by skilled health personnel. So we're not doing badly that way. I think we're doing pretty well that way. In terms of our adolescent fertility rate, we can see that for us, we have 52 births per 1,000 women between, this is actually not just 15 to 19, 10 to 14 and 15 to 19 years. So 52 births, and we can say that if this is comparing us to our non-Latin Caribbean neighbors, we can see though that we are amongst the top quartile, I will say. Only exceeding our adolescent fertility rate would be Guyana. That's it. So our adolescent fertility rate is higher than our Caribbean partners, and there's probably a role for some intervention there. The United Nations in 2015 set about some the world as a whole would have an acceptable level of health and productivity and quality of life and environmental health and so on for its citizens. And the Sustainable Development Goal as related to health is 3, and the aim is to ensure healthy lives and promote well-being for all at all ages. So the Sustainable Development Goal 3.1 speaks to the maternal mortality ratio, and it is hoped that the whole world by 2030 would be able to get their maternal mortality ratio to less than 70 per 100,000 live births. So where are we in Jamaica? We are at about 80 per 100,000 live births. The numbers differ, and some I think are raw and then adjusted numbers. But I think what is important to note is that we have had a sustained decline in our maternal mortality ratio over the last 2.5 decades. So we're probably, the latest figures I see put us around 80, 85 per 100,000. So we are getting closer to the 70 per 100,000, and we hope we'll get there well ahead of 2030. The Sustainable Development Goal as relates to children is 3.2, which speaks to promoting healthy lives and well-being for all children. And 3.21 wants to end preventable deaths of newborns and under 5 children by 2030. Two targets that they had were to reduce the newborn mortality to as low as 12 per 1,000 live births in every country, and to reduce under 5 mortality to at least as low as 25 per 1,000 live births in every country. All right, so where are we in Jamaica? Our top at UHW, I review our data every year, and our top contributors to neonatal mortality include low birth weight and prematurity. And this would speak to just the difficulties we have as a middle developing country in sustaining particularly the most premature and the smallest newborns. Also, respiratory disorders. RDS speaks to respiratory distress syndrome, which is a complication of prematurity where the lungs are immature, and so the newborn has difficulty maintaining normal ventilation after birth. Then we have infections following, and then infants of diabetic mothers. And the next in line would be birth asphyxia, which speaks to problems with the newborn sustaining, adapting to life after birth. So they'd have problems with breathing, problems with their heart rate and circulation, and this can cause damage to the brain, ending up in cerebral palsy and even death later. So at UHWI, these are our top contributors to morbidity in newborns. But nationally, what we will see is that, again, our neonatal mortality rate has shown a steady decline over, this is showing 60 years of data. So you can see that there's been a steady decline. This chart shows up to 2015. And the most recent data I was able to find was for 2018, where our neonatal mortality rate was 15.2 per 1,000 births. And you remember that the goal is to get to 12 or less per 1,000 births by 2030. So again, I'm heartened by the sustained reduction in the neonatal mortality rate. And I think that our country is hopefully well on the way to attaining and surpassing that goal. So Jamaica's response to these sustainable developmental goals for maternal and neonatal health was to develop a program called the Program for the Reduction of Maternal and Child Mortality through the Ministry of Health and supported by the European Union. And what this program aimed to do was to reduce, the incidence of neonatal deaths due to lack of access to high dependency care. So I explained to you that one of our chief contributors to mortality was prematurity, and of course, the ability to support premature newborns. There are gaps within our country. As a matter of fact, there are few high dependency units throughout the island. So one of the goals was to increase the access to high dependency care, to reduce the incidence of maternal deaths due to lack of access to emergency obstetric care, and to improve the quality of management of high-risk pregnancies at both tertiary hospitals and primary care clinics. And this they did by establishing high dependency units. So they strengthened UHWI, they strengthened Victoria Jubilee Hospital, they strengthened Cornwall Regional, establishing at St. Anne's Bay Hospital, establishing at Spanish Town Hospital, Mandeville, and so on. So really spreading this level of support throughout the country, and not just restricting it to the major or larger hospitals. Also, the program aims to train and is training more newborn specialists, so neonatologists who are equipped to manage these high dependency units, and therefore to offer more specialized care for our premature and ill newborns. The program also trained specialist obstetricians to develop, to deliver care to our high-risk women, and these are our fetal maternal specialists, and also to be able to detect illnesses and abnormalities in the unborn child by proper screening and evaluation. So this is our government's response to the challenge to reduce neonatal deaths, maternal deaths, and improve the quality of maternal and neonatal care for our nation. Another sustainable developmental goal, reduce under 5 mortality to at least as low as 25 per 1,000 live births in every country. So how are we in Jamaica? So up until 2013, we were at 17 per 1,000 live births for under 5 mortality rate. So we had already met that goal. And as you can see, the under 5 mortality rate also continues to decline annually. How do we compare to our partners? So again, these numbers will fluctuate, I guess, based on whether or not they're raw or adjusted. But as you can see, though, that I always look at my non-Spanish speaking Caribbean neighbors. I have colleagues in Barbados, Bahamas, and so on. And you can see that again with Guyana and now St. Kitts and Nevis, we are, although doing better, I think we are not leading the pack among the Caribbean countries. And this really speaks to our socioeconomic status. A number of these countries, Bahamas, Barbados, and so on, are higher middle income and I guess have more funding for healthcare. So the top contributors to deaths of children under 5 in Jamaica include prematurity, congenital anomalies. So these are congenital abnormalities that babies are born with. And so we should be able to tackle this some more with the training of our fetal maternal specialists. Birth asphyxia, which I spoke about before, respiratory infections, injuries, sepsis, diarrhea, and so on. As you can see, very little HIV, AIDS, very little. Another index of our delivery of appropriate healthcare to our under 5 children is our immunization rates. And as you hear everybody boasting about that Jamaica has a very strong positive record of successful immunization over the many decades. And this is typified by this chart, which shows that for all the routine immunizations, our rates are around about 95% and above. We'd love it to be 100%, right? So even that 95%, there's still room for improvement, but all of it, I think except for one vaccine, which was 94%, is at 95%. These for which there are no data, rotavirus and the pneumococcal vaccines, these are not done routinely in Jamaica, but done routinely in other member countries of PAHO. So how are we doing for health as it looks at nutrition of our children? So what we're seeing here again is that we have had a decline in the percentage or numbers of children who are undernourished, so low weight for height over the years. And you can see that we're down to like 3.6 per 1,000 and quite low. And funnily, what you will notice is that even though I spoke to us, our income level not being higher middle income, we're even leading our higher income Caribbean neighbors in terms of eradicating undernutrition. Similarly, in terms of stunting, our levels are quite low as well. And this really speaks to decades of health delivery to malnourished children, really out of our University of the West Indies. And you know, we've trained a lot of nutritionists and doctors to manage, to prevent and manage protein energy malnutrition, so much so that we had to close the unit within the last 2 years because we had no patients to treat for malnutrition. So I think this is a success for our country, and I hope that we will not lose the gains after COVID. But on the other hand, in terms of overweight, you can see that we are increasing in our numbers of overweight children under 5, and this is up to 2018. And so we know that we now have to turn our attention to proper nutrition and activity of our children. And again, I think COVID threatens that with all the lockdowns and children unable to go out and play, no physical education in schools, no participation, reduced participation in sports, lots of time in front of the screen and continual snacking. In terms of our older children, so our adolescents, the main threat to their health has to do with exposure to violence and safety. So we see, regrettably, that 71.9% suffered some kind of psychological punishment from a caregiver. And that is going to redound to their behavioral issues later, and, you know, non-social behavior patterns later. 70% of all Jamaican children experience physical punishment at home. 5.7% experience severe physical punishment. And as we know, males are more likely than females to experience violent discipline. And the same is true for children in rural areas in Jamaica compared to urban areas. And so children in the poorest quintile were more likely to experience physical punishment and severe physical punishment when compared to their peers in the wealthiest quintile. Regrettably, exposure to HIV is still a threat for our children. And this largely is due to child abuse and sexual abuse, and early sexual initiation and debut by our adolescents. So as adolescents age, the risk for HIV infection increases, and adolescents aged 15 to 19 were 5 times more likely to become infected with HIV than younger children. Regrettably, there are many young women who have become HIV infected because of rape and sexual abuse. This data was very difficulties with this, that transactional sex, 24% of girls aged 15 to 19 and 54% of boys in the same age group are engaged in transactional sex. Or teen pregnancy rate, you saw that from our other figures, is the 3rd highest in the English-speaking Caribbean. And then in terms of mental health, 42% of all attempted suicides treated at public hospitals were children. And 72.5% of students who are at risk for suicide are in the 14 to 19-year-old age group. So you can see that what confronts our older children and adolescents now is abuse of all types, exposure to violence, and the mental health issues. So in terms of our mortality rate amongst our 5 to 14, that also has shown a steady decline over the decades, and similarly in the 15 to 19 age group. So what are the opportunities for strengthening child and adolescent health? I think in addition to all that we've seen that the Ministry of Health is doing in terms of maternal and child health, I really believe that there is a need to strengthen the mental health care and delivery of our adolescents. And we have to begin by strengthening the capabilities of our healthcare workers. So many people, many times adolescents will present, they don't come in and say, I'm depressed. They come in with headaches and problems sleeping and all sorts of pains and difficult behavior. And if you screen them, often you'll find that there's a significant proportion of them who are depressed. You'll also, we sometimes are afraid to ask, but as we're reminding, asking does not cause this to happen, but we must ask about suicidal ideation and intention, because many times the children and adolescents want help, but they won't come out and ask for it. And so we need to be able to routinely screen these children for these mental health conditions, ask about these particular risks, and see how we can support the families. And if we can't support the families, how we can ourselves, how we can refer them for the necessary support. So I think we have to strengthen our mental health skills and services. We need proper teen support programs. So the data is there. The teens who do well are the teens who have good support. Has not to do with financial wealth, but we know that there are the teens who are involved in youth clubs, that attend church, that have an adult who is caring and supportive consistently, and also a father who is present in the home and who is supportive. So we know what the recipe is for successful success and thriving of our teens. And so we now need to translate this in a greater way. It happens, on occasions, but in a broader way to teen support programs. And when our young people present, well, even before they present pregnant, there needs to be some education about parenting, because many of us don't have the examples in our homes and our upbringing, but there are some fundamentals that can be taught. And then certainly when they do present for healthcare, and especially for those who are presenting with teen pregnancies, apart from just getting through the delivery safely, I think there needs to be proper support of the teen and that family in terms of parenting. And then we have to create the safety nets. So what do we do when this teen or young person cannot be adequately supported in their own family setting? We have to create those safety nets. Well, what about COVID? This is not my own, these are my own thoughts, but this is again from the WHO website, that although COVID-19 is doesn't affect children to the same degree as adults. So the children tend to get milder illnesses, although there is a risk of severe illness in a small proportion of children who get COVID-19, and in certain risk groups, like we know children with sickle cell disease tend to do worse with COVID-19. But apart from that, COVID-19 threatens to divert resources from child health to address the pandemic among adults, and this may further impact care of our children. We also know that the poor living conditions in lower middle income countries, and even in our Jamaica, including lack of sanitation, running water, and overcrowding, can facilitate transmission of the virus. And then there are indirect effects of the pandemic on child health, including increasing poverty levels. We're seeing that where parents have lost their jobs and income, potential to earn income at this time. Disrupted schooling. Schools are a safe place many times for children. Many children are nourished by school feeding programs. The lack of access to school feeding schemes, reduced access to health facilities, and the interruption, turning our eyes from our vaccination programs for children to like the vaccination program against COVID and all that comes, rightfully so, with addressing the COVID pandemic, but there's a risk to child and adolescent health. Other things include the inability always to implement effective public health measures, and we know that. And we know that continued schooling, which is crucial, is very challenging in these overcrowded resource constrained settings. And so this again brings up, as we all are grappling with this global inequity in health in lower middle income countries, we know that the pandemic has really shone the spotlight on that, not in terms of just dealing with the pandemic or access to vaccines, but also how this has the potential to impact the gains that we've made in child and adolescent health and maternal health. But it also, if we recognize these threats, provides the opportunities to strengthen child health in these settings. I think that's my last slide, and I thank you.
Thank you so much, Dr. Mebourne-Chambers. At this time, I'm going to invite Rotaract Sharissa to move the vote of thanks for us.
Thank you, Secretary Andre. Dr. Chambers, on behalf of the Rotaract Club of Mandeville, I want to express our greatest appreciation for the information passed on to us today. I do believe that the need for strong parenting programs is definitely a reason or cause for so much of our children facing some of the issues that they are. And so I do agree with that point. The information was well received, and I'm sure we all have some takeaways from this today. So once again, we thank you so much.